Hello and welcome back to KINE 404, an introduction to epidemiology. My name is Richard Armenta, and in this lecture we're going to talk about social behavioral epidemiology and really focus on social determinants of health and how they lead to health disparities in our communities. So our objectives for today are to define social determinants of health, understand the role that social determinants of health, which is abbreviated as SDOH here and will be in many places, understand the role that social determinants of health have on health and well-being, discuss how racism, hate, and discrimination impact health, define and describe health disparities, and discuss the challenges with addressing social determinants of health in research. So as we're going to do with many of the lectures in this class, we're going to start with framing this lecture with what epidemiology is as a field to remind ourselves why we're discussing some of these things. So epidemiology is the study of the distribution and determinants of health-related states or events in human populations and the application of this study to prevent and control health problems. So in this lecture and in this portion of the course, we're going to talk a lot about how things that are outside of individuals' control can impact their health, namely especially things like discrimination, racism, and hate. And these are often topics that are really taboo to talk about and that make people feel uncomfortable, especially when we're talking about it within our own communities that we might live in. But something that I want you all to think about throughout this lecture and throughout this course is how things that we all experience throughout our lifetime, and we'll look at this eco-social framework again in just a moment, and that life course perspective to health, how these things that we don't have control of and that often other people and our government and outside forces place on us, how those impact our health overall. Because much of what's defining the health of our communities and our populations are not our own individual behaviors, but rather how those behaviors and how our genes and how other things are impacted by these larger social and structural factors that are influencing our individual behaviors and our health, not only as individuals, but the health of our communities that we live in. So this is where social epidemiology comes in. Social epidemiology is the branch of epidemiology that studies the social distribution and social determinants of health. That is, both specific features of and pathways by which social conditions affect health. The goal of social epidemiology is to identify social environmental exposures that may be related to a broad range of physical and mental health outcomes, because the vast majority of disease and other health outcomes such as functional status, disability, and well-being are affected by the social world that's surrounding us all. And if we ignore these social and structural factors, we're going to ignore the root causes of disease, and we're not going to be able to improve the health of all of our populations. So what are social determinants of health? And these definitions come from the World Health Organization as well as other organizations that have done a lot of work in this area. Social determinants of health are the circumstances in which people are born, grow up, live, work, and age in, and the systems that are put into place to deal with illness. These circumstances are in turn shaped by a wider set of forces, including economics, social policies, and politics. And these are the things and the reasons why we can't separate politics from health, because so many of our policies that are developed by the government are affecting different communities in different ways. And sometimes the way that those policies are affecting different communities are leading to differences in health status. And those are called health disparities, and we'll give a better definition of that later on in this lecture. And these social determinants of health are mostly responsible for health inequities or differences in these health status and the unfair and avoidable differences in health status seen within and between countries globally. And so if we think back to that eco-social framework that we talked about in the first lecture of this class, we can look at through the life course and throughout our entire lives, all of us are interacting with the environment that surrounds us, whether that is the social and economic policies such as is smoking allowed, what are taxes on cigarettes, how are schools funded, all of those things, or the institutions that we interact with, What does our education system look like in our neighborhood? What does our local government and policies look like? How many parks do we have access to? Are there more fast food restaurants and farmers markets in our neighborhoods and communities? Are we living in poor living conditions where we might not have adequate access to running water and or electricity or basic needs that we all require to be able to live a healthy life? What do our social relationships look like? And how does that in turn influence our individual risk factors and behaviors that we engage in? And how do all of these conditions taken together impact our genes and other factors, and then lead to pathophysiological differences that can impact not only our individual health, but also population health? So one thing I want you to think about as you're going through this portion of the course and throughout the rest of the course is where you grew up. What types of things did you have access to when you were younger? Did your family have health insurance? Did you go to the doctor regularly? Did you get regular dental checkups and teeth cleanings? Did you exercise with your family? Was there a park in your neighborhood? What type of food did you eat and why? All of these things taken together are influenced by our family environment and the structural environments and our socioeconomic status and where we live. And we have to be able to address these factors if we want to ensure that all people have a right to health and the ability to live a healthy life. And often this eco-social framework and this life course perspective within public health is put into what we call the social ecological model, which is a theoretical framework for understanding how factors outside of a person's control influence health and wellness at various levels surrounding that individual. So these are all things that we just briefly talked about, and those include things like structures and systems that we live in, federal, state, and local regulations and laws, the built environment and infrastructure, community level things, such as relationship and community relationships between organizations and institutions, and the schools that we go to, the healthcare organizations that we have, what types of faith-based organizations are available, and how those all impact our interpersonal relationships, such as support groups, social networks, the cultural context, and the culture that we'll live in. Because different cultures have practiced different things, and the way that those are practiced and the way that people are able to practice their traditional culture can impact their health. So if we look at this from the example here on the right-hand side, we can look at it everywhere through this social ecological model for things that impact physical activity. So if we want to look at what impacts physical activity, that could start at the structural macro-social factors: political economy, discrimination, history, culture, institutions. So let's say that there's structural changes that are made toward the development of safe parks and recreational areas, and the sidewalks are kept up so that people can walk safely outside. So that would be a structural level factor that is used to improve physical activity because it allows people more opportunity to engage in higher levels of physical activity. Whereas if we have another neighborhood where there's broken sidewalks, there's not a lot of parks, or the parks are not clean, or they're not safe because there's a lot of violence in the neighborhood, then that structural environment is not set up for people to be able to be physically active. We can look at community level things, where you might have a town with disproportionately low access to fresh fruits and vegetables because there's just not farmers markets that are close by. And there's not a lot of opportunities for, there's more, say, mini markets where people can go and buy processed foods and sugar-sweetened beverages and other things that don't give them the access to the resources that they need to be healthy and to have a nutritionally balanced diet. And the fact is, in many environments, that there's more fast food restaurants, especially in low socioeconomic neighborhoods, than there are access to fresh fruits and vegetables. And often the fast food and the processed foods are less expensive. So if you have a family that's low socioeconomic status, then they may not be able to afford the healthier foods, or they may not know the benefit of the healthier foods. So then we can get into institutions and organizations. So we can look at What does our school system look like? What's being taught? Is PE an important part of school where children at young ages are being taught why physical activity is important? Are there those access to safe parks in the neighborhoods that people live in that need it? And then what do those interpersonal relationships look like so we can see how people's friends and family are engaged in these things? Is it culturally valuable to engage in physical activity? Do you have a lot of friends who are engaging in physical activity and eating healthy diets? Are there support groups? Are there things that people can engage in with their networks that can help them live healthy lives? And these all lead down to individual behaviors, that all of these larger factors influence the behaviors that we have as individuals. So if you grow up in a family that's super athletic, where that's valued and where education's valued, you're more likely to go into that. Whereas if you grow up in a family where education hasn't been attainable because of the socioeconomic status and the neighborhoods that they grew up in, then you're less likely yourself to go on and engage in those activities yourself. And so these are all things that we need to address. And if we're thinking about it in the framework of physical activity, we need to address them throughout a person's life. So provide stable housing, provide good quality foods, provide good education that's equal across all populations so that everybody understands the benefit of these activities. And so these social determinants of health that we've talked about and how we framed it within the social ecological model, where these factors that are exogenous or external to a person's individual behaviors that influence an individual's behaviors can lead to what we call health disparities. And health disparities are a particular type of health difference that are closely linked with social, economic, and/or environmental disadvantage. So when we typically talk about health disparities, well, we talk about them as adversely affecting groups of people who have systematically experienced greater obstacles to health based on some type of membership they have in a group. So we often talk about it as health disparities by race ethnicity, and we'll talk about race ethnicity in more detail in just a moment, or religion, disability status, socioeconomic status, sexual orientation or gender identity, sex or gender, age, mental health status, based on discrimination and racism, geographic location, social location, and a combination of other factors. And one thing I want you to think about is how your individual identity might shape your health, and whether or not there's things that you've experienced as an individual that have led to particular health differences or health outcomes that might be more likely in specific communities as a result of those things that we experience. So one thing that I mentioned is that we're going to talk a little bit more about race and ethnicity. And so what I want you to think about is, what is race and what is ethnicity? And often I think we get misinformation about what race and ethnicity are, and people are put into these groups based on some characteristics that we say is defining who they are. And often we talk about race as being some biological construct, but actually race is more correctly a social construct, and it's grouping of human beings based on some physical or social qualities that are usually viewed as distinct by society. But one thing I want you to actually take away from this is that there's actually more variability within individual races than there are between them. So there's research that shows that there's actually more variability within those who are identified as Black versus those who are, and within those who are identified as Asian, those who are identified as white, than there are between the races that we see. And this is for a number of factors. And one of the things that we often do is we group people into these categories and say, you're all different because you're white versus Black versus Asian versus American Indian and so on. But what that ignores is that within all of those categories, there are large differences within those groups of people. So when we talk about, say, Asian, there are multiple different Asian ethnicities, and ethnicity is typically thought of as grouping of people who identify with each other and have shared language, ancestry, culture, society, and so on. So when we talk about race being Asian, which is how we identify that in the United States and in many other countries, well, what does that mean? Does that mean that somebody is Filipino? Does that mean that somebody is, and that's, Asian and Pacific Islander usually grouped together, or Chinese, or South Korean, or Vietnamese, or any number of ethnicities where people have grown up in a culture in a different country or a different area, and they have similar values and culture and language and ancestry. And by grouping people by race ethnicity, we are often ignoring these larger differences that can lead to health differences. And these groupings have led to issues for people within the United States and globally that has led to health disparities, which is why we often talk about race ethnicity as being one of the major drivers of health differences in our population. We'll talk about some examples of that in just a few minutes. But one thing I want you to think about is, does race and ethnicity affect health? So we often see data and statistics that says something like those who are Latinx have higher rates of type 2 diabetes than those who are white. Young black men in the United States have higher rates of HIV than young white men in the United States. And we can see data like those who are Mexican American or Latinx have higher rates of cardiovascular disease or cancer or any other disease, and we see these disparities rampant in our population. But is actually those populations' race ethnicity that's affecting their health? Is there something about the genes of somebody who's a young black male or a Latinx community member that makes them more likely to have type 2 diabetes or HIV or any number of diseases? And so that's something I want you to think about for a moment. So you can even pause it and think more deeply about this and think, does race ethnicity actually affect health? And if it doesn't, what is it that's actually affecting the health of our communities? And so I'm going to say that race ethnicity doesn't affect health, that it's actually discrimination and racism that's affecting health. And so we're going to go through a couple of definitions and talk about how discrimination and racism affect health and a little bit of the historical context about these topics. But one thing I'm going to mention here is that we're not really going to do this topic justice, and we're going to have one section of this in this one lecture, but there's really a whole host of literature that points to the fact that these are really what's driving health disparities and differences in health status. So discrimination is the unjust or prejudicial treatment of different categories of people or things on the grounds of their identities. So basically saying, I'm going to treat somebody different because of the color of their skin, or because of their sexual identity, or because of some other way that they identify their religious affiliation or whatever that is. Racism is a system of structuring opportunity and assigning value based on the social interpretation of how one looks, so their race. And racism unfairly disadvantages some individuals and communities. It unfairly advantages other individuals and communities and saps the strength of the whole society through the waste of human resources. Really what racism is prejudice plus power. So it's the notion that some people in this country, based on their physical characteristics, and in other countries for that matter, have more power and they're better than other people, solely based on these social interpretations of how somebody looks. And so this is something that we need to think about thoroughly in terms of how it impacts our health. And there's many different levels of racism, including personally mediated or individual interpersonal racism. And these are individual acts of discrimination and prejudice, stereotypes, and hate, and things that we're seeing all the time in the media, on social media, and in our communities. And this includes things like implicit bias and explicit bias, where implicit bias is unconscious attitudes and beliefs that people have. So for example, if a white medical professional won't look an African American or a black parent in the eye and only talks to their white partner instead while they're attending an ultrasound appointment, that might be implicit bias because that person's not wanting to directly talk to that African American parent or that patient. because of some unconscious fear or mistrust or judgment of non-white people. And this happens all the time in our medical system, actually, and something that you'll learn about when we talk about medical racism being a really big problem. Explicit bias is more overt or intentional acts that are practiced by individuals. So that could be using a racial slur against somebody, or it could be a police officer calling somebody an ethnic slur while arresting them, or walking on the other side of the street because you see somebody coming up that has a different color skin than you, or whatever that might be. The other types of racism that we see that fit in with our social determinants of health definition are institutional and structural racism. And this is the unfair policies, practices, and procedures of particular institutions and systems that routinely produce racially inequitable outcomes for people of color and advantages for white people. And when we say people of color in this, we mean, Black and brown communities in our population. This is often used as a way to describe Black and brown communities. And we have to recognize that racism is not just individual acts of hatred, bigotry, prejudice, or stereotyping, but that our systems that we live in have actually been set up in a way that disadvantage different groups of people, whether that is based on where that somebody can live, where they can work, where they can get an education. And we've seen this throughout our history, where certain groups in this population, mostly white people, hold a lot of power and dominance, and they control the political systems and the narrative that we have about social norms and culture. And this can lead to health differences in our population. And this often leads to what we call internalized racism, which is the process by which people of color adopt racially prejudiced attitudes and behaviors that lead to discrimination and stereotyping of their own racial group. It's a form of systematic oppression where people in communities of color unconsciously sometimes can support white privilege and power. And so these are all things that we need to think about because it's so ingrained and within our society that it leads to these issues that we're facing today in health disparities and job disparities and economic disparities within our communities. So you might be wondering, how has racism and hate impacted our communities? And it's done so in many ways. Because present day hate, which includes racism, sexism, homophobia, religious persecution, and so on, and we see this all the time, has been built on a long history of racially and unequally distributed resources and ideas that shape our own view of ourselves and others. It's a hierarchical system that comes with a broad range of policies and institutions that keep it in place. And institutional racism has been responsible for slavery, settlement, Indian reservations, segregation of our schools, residential schools for American Indians, internment camps, and many other examples through our history. And these historical events have all had long-term impacts on our society and different cultures. And as a result of this has led to health disparities and disparities in employment acquisition, housing, education, healthcare services, government resources, and a number of other sectors. And if we frame this within that social ecological model, and we look at anywhere from the systematic level down to the interpersonal and intrapersonal level, we can see that there's a number of ways that the policies, such as who is getting thrown in prison and jail more in our communities, who's able to immigrate to this country and get citizenship. Or we look at things like hiring and promotion practices, where there's been studies that's shown that even based on a person's name, that sometimes somebody won't get an interview for a job because their name is deemed as coming from a certain race ethnicity. Or where we're undervaluing or overvaluing contributions from certain communities, where often in science, we ignore the contributions that people of color are making that are advancing our science and our knowledge forward. And so that's something that I want to think about, is where does our knowledge come from? And who is it coming from? And how are we valuing that knowledge? And are we ignoring important knowledge that can have an impact on the health of our communities? And if we look that down to the interpersonal level with overt discrimination and implicit bias and how those interactions can impact an individual's health, especially if they're dealing with things like implicit bias within the medical system, where they're not getting the same treatment as others because they're not believed about their symptoms. And this all can lead to internalized racism, stereotype threat, embodying inequities, and even sometimes we've shown in research that these experiences that people of color have from discrimination and racism have led to differences in gene expression that lead to different rates of disease in those population. And this research is still emerging, but we've shown this in certain communities that it's not those innate genetic differences, but it's the fact that we're seeing different genetic expression, and we'll show this through a model that I'll show you in a little bit that's led to differences in health status in different communities. And so I'm going to go through a couple of examples of health disparities that we've seen in our population in the United States. And we're going to start out with just talking about health disparities by education. So let's start on the top left figure here, where we see the percentage of US adults age 18 or older with diagnosed diabetes by education level from 2013 into 2015. So what you can see in this figure is that as education level goes up, so you go from less than high school on the bottom to high school to more than high school, that the percent of people with type 2 diabetes decreases, where it's almost half the amount of people who have the prevalence of type 2 diabetes is almost half that among those with more than a high school education compared to those with less than a high school education. We can also see that with maternal mortality per 100,000 live births. So if we look at on our y-axis on this second figure, this is pregnancy-related deaths per 100,000 live births. So this is essentially women dying during pregnancy or shortly after pregnancy. And we see huge disparities in maternal mortality by race ethnicity, where we have the lowest incidence and prevalence of maternal mortality among white women compared to Black women and American Indian or Alaskan Native women. And that across education levels, that these disparities exist. And that it's not just the fact that getting an education is going to improve a person's health outcomes, but that sometimes there are other factors that are playing a role. And these disparities illustrate that when you look at those who are college graduates, that Black women still have almost 4 times or over 4 times the maternal mortality rate compared to white women at the same college education level. And you'll hear about this a little bit in the podcast that you'll listen to too. And I also encourage you to look up Serena Williams' story about her pregnancy and what happened after she gave birth. We also see this with this bottom figure over here, where we break this down within different racial ethnic groups. And we can see that there's a higher rate of severe maternal morbidity, so severe complications from pregnancy, and this is in New York City, when we compare across education levels, that there's still higher rates in Black, non-Latina, Puerto Rican, and other Latina and Asian Pacific Islanders when compared to white women. And so this is a disparity that we see that doesn't go away just by getting education. And so we see these disparities that are existing by education, and we see these disparities that are existing by race ethnicity as well. And that we can't ignore the fact that many of us have multiple identities that we share, and that we have these competing identities that can impact our health. And if we talk specifically about how education impacts health, there's one model that's shown here, and there's many others, and there's more complicated ones that you'll read about that can look at how education impacts health. One pathway is through creating opportunities for better health. So education can lead to higher income. It can teach about healthy behaviors. It might mean that somebody lives in a healthier neighborhood, and it has social and psychological benefits. And then on the flip side, being healthier can impact education, where people who are in poor health can put their education at risk, because people who have poor health are less likely to have good attendance in school, they're less likely to concentrate well, they might have a higher number of learning disabilities that makes it harder for them to do well in school. And if those schools don't have the right support systems for individuals who are in poor health, then they're systematically disadvantaged at accessing higher levels of education, which can improve their income and resources. So we see this cycle where people who are in poor health have lower access to education. That education is needed to improve their health and improve their social status, economic status. And so that cyclical cycle can lead to health disparities. And these are all framed within these contextual factors of social policies and individual and family characteristics that are happening throughout a person's life. So things like social policies and governmental policies, such as how our education system is funded, where it's coming from taxes. And as a result of this, certain communities are immediately disadvantaged because there's less taxes being paid in those communities. So their schools aren't funded as well. And so that means that those children may not be receiving as good of an education and might be, from the time that they're starting school, less likely to go on to get a college education because they're not as well prepared and it's not as valued because it's not taught in their communities. And so these are all things throughout a person's life course that can impact their right to health. And I've already mentioned this, but we've seen higher pregnancy-related mortality among Black and American Indian Alaskan Natives. And these gaps haven't changed over time. So if we look at how this data is changing, we still see these higher rates among Black and American Indian Alaskan Native women comparing to white women in our population, where we see 2 to 3 times higher number of maternal mortality among Black and American Indian women compared to white women. And so when we talk about some of the key determinants of health, what we usually talk about are things like race, ethnicity, low income, low education, inner city or rural, or lower developmental country. But what we really should be talking about is racism and discrimination, food access, social support, unemployment levels in different communities, what type of work and jobs that people are getting, such as are people in higher stress jobs because they're very physically demanding and they're having to work multiple jobs to support their families. What early life exposures do people have? So where do people live and how does those environmental exposures that they live in impact their health? So that could mean that they live near farms where there's lots of pesticides. That could mean that they live near lots of plants or near a freeway where there's lots of pollution. How is their stress impacting their health? Because we can see from research that stress is a big factor that influences health overall. And social gradient. How does their socioeconomic position influence their health? And there are many different pathways by which social determinants of health and the things that we've talked about can lead to poor health and health disparities. And this list just gives some of those, and those include things like allostatic load, which we'll talk about in just a moment, access to resources. Do people have good access to healthcare services? But more than that, it's not just about access to resources. It's about having the right access at the right time when a person needs it and the right doctor for the right health condition that that person is facing. So for example, and this is a problem that we see often in San Diego County, where you have monolingual Spanish speakers or monolingual Tagalog speakers, or even in San Diego, we have some of the, we have one of the largest populations of indigenous people from Oaxaca, Mixtec and Zapotec people. And many of them are monolingual Mixtec and Zapotec speakers. And so what that means is that if they go to the doctor, they may not be able to find a doctor who speaks their language. And so then they may not be able to understand what the doctor is telling them about their health or even what the health condition is, because sometimes different languages don't have the words that are needed to express health in those populations. And so these are all things that can impact health that we need to be able to understand and make sure that we're educating the right populations to be able to get these jobs, like being doctors and researchers, to address the health issues in their communities. Other ways that social determinants can lead to poor health is things like exposure to toxins and pollutants, abuse and neglect in the family, lack of knowledge about how these things impact health, unhealthy habits because of that lack of knowledge, and social influence by the things that surround us. So the one that I want to provide a little bit more detail on is what we call allostatic load. So allostatic load is prolonged neurochemical imbalance that has negative consequences for normal neural function. So this is called allostatic load, or the cost to the brain and the body of continual allostatic response to stressors. So essentially, allostatic load, what it means is that our body is responding to stressors that we have in our environment and in our lives that leads to these neurochemical imbalances that can lead to altered neural function and gene expression, among other things. So if we look at this pathway of allostatic load, if we think about things like major life events such as getting in a car accident, pregnancy, trauma, abuse, environmental stressors like having really stressful jobs, or home stressors like there being abuse or neglect, or living in a neighborhood that's unsafe, or being stripped from your culture and being put in a boarding school like American Indian communities had to face, or having your land taken from you, or having your rights taken from you. Those are all events that lead to stress in different communities and individuals. And so our brain and our bodies will evaluate this stress, and there will be the release of hormones and cortisol and other things that can lead to individual differences on one side, where we see differences in gene expression and development and experiences, and behavioral responses, where people might, as a result of these stressors, be more likely to engage in health-related behaviors like smoking or alcohol use or unhealthy diets, or be less likely to exercise. And all of this combined has physiological responses that this allostasis, or this adaptation, happens, and we have this allostatic load that's leading to these differences in our bodies that can lead to differences in health status. And we've seen this in many different communities, and it's something that if we're not addressing these social determinants of health, then we're not able to intervene on the things that are actually impacting a person's health. And so this is what I want you to think about is, what are these main drivers of health in our communities, and how can we address them? And part of the way that we can address these things is through how we talk about health and how we talk about social determinants of health. So one thing I want to empower you all to do is think about, how can we make a difference, and how can we address social determinants of health? And that includes things like saying health starts long before illness in our homes, schools, and jobs. And health is something that we have to work out our entire lives. And we have to address these social structural factors that lead to poor health in order to improve the health of all of our communities. And the opportunity for health begins in our families, in our neighborhoods, in our schools and jobs. So that means that we should all have access to safe places to exercise, to healthy foods, to good education, and to jobs that provide us the resources that we need to live a healthy life and to support our families. And the opportunity for health starts long before you need medical care. So well before any of us get sick, there's things that we're experiencing that can lead to those illnesses, and there's things that we can do to prevent that. That includes things that many of us take for granted, such as having stable housing or having access to health care. But it also includes many other things, such as having your culture valued, having you as a person and your population valued. And all Americans should have, and all people globally should have, the opportunity to make the choices that allow them to live a long, healthy life, regardless of their income, education, or racial ethnic background. And your neighborhood or your job shouldn't be hazardous to your health. Where we live, what we have exposure to, those shouldn't be the things that we're driving our health. And the way that other people treat us shouldn't be the things that are driving our health. And one of the parts of this portion of the class is you're going to listen to a podcast by Abdul Al-Said. And the podcast is called America Dissected, and you're going to listen to the podcast Cradle and All. And at the end of that podcast, there's a quote by Leslie Welch, who's in the podcast, that says, "We're not at the limitations of our science. We're at the limitations of what we believe about one another. We're at the limitations of what we're willing to let go of, or give up, or do differently to improve our lives." And I think that this quote is extremely powerful, because we have the research and we have the science that shows that our policies that discrimination, that racism, that hate are all impacting the health of our communities. But that many of us don't want to have these uncomfortable conversations and don't want to do the things that are necessary to address these issues because it might make us not feel uncomfortable. Or we might have to give up one level of comfort to help others in our community. But if we want to all have access to good health and we all want to improve, we need to ensure that that's opportunity and those opportunities that we need are the same across different populations. And that if we're able to ensure that everybody has access to these things, that we're all going to improve together. And it's not just about our own individual health, but it's about the health of our communities. And so, as I said, this lecture is really just touching on some of the main issues with social determinants of health and health disparities to introduce you to these concepts. These will come up throughout the readings and the discussions and the projects that we'll do throughout the class to help you explore different areas of health disparities and social determinants of health. But I really want to encourage you all to think about how the way that we treat others and the policies and where we grew up and how we live, how all of those things influence health. And take this really out of our individual behaviors and controls. And some of it, I don't want to say that none of our health is about our own individual behaviors, because it is. But that often those things are influenced by things that are outside of our control. And those are really a lot of the drivers of our health overall. So thank you, and let me know if you have any questions.